And what is the biggest myth about the hysteroscopy?
Well, it can't be done when the patient is having irregular periods or when the patient is having little bleeding. And the more important is they think it is painful process with lot of anxiety.
Can hysteroscopy prevent future surgeries?
Yes, obviously. That's what I discussed. You need not have to go for hysterectomy. Many of the cases you can prevent.
Okay. Like one thing women should not ignore about the reproductive health.
Well, they should go for routine screening. That's important.
Okay.
And if they have heavy menstrual bleeding also, they should return to the doctor, not get very weak, anemic and then come. That's what we find in women. Hemoglobin goes down to 6, 7 and then they come and see the doctor.
Treated using the operative.
Mostly we do polyps, fibroids which are in the cavity. The FIGO, we have a grading for that. FIGO 0, 1, 2 can be done with the hysteroscopy. And slowly when it goes into the myometrium, we need more expertise to remove those fibroids.
Dr. Anuradha ma'am, first of all, thank you so much ma'am for your valuable time today. Welcome to the Healing Hours. So today's the topic will be on the hysteroscopy. So we'll start from the basic first. So ma'am, could you please explain what is hysteroscopy?
Hysteroscopy is a method where we visualize the inside of the uterine cavity. We have a telescope, like scope. It's like a telescope with a light source. So we introduce that through the vagina to the cervix into the uterus, and the uterus is distended with a distending medium. It could be normal saline or it could be other things when you are doing operative scopy. So there's a distension medium and we can pick up things. It is something like you see and you treat at the same time if there is anything necessary.
Okay. And how it is different from the operative hysteroscopy?
See and treat. That was when you have to see something, you find a polyp, you find a fibroid, or you find something else in the cavity. So we can, at the same sitting, change it to operative hysteroscopy and remove the structure. So the operative hysteroscope is different from a diagnostic hysteroscopy. When you just see, it is diagnostic. When you operate, you change the resectoscope sometimes, or you may have pins like a bipolar pin or a scissor which can be used to cut smaller structures. When you have a bigger fibroids, you have more of adhesions, and then you can use a resectoscope and Collins knife as well.
Okay. So
and energy source. So that for use for cutting. Sometimes you use a cold knife, like you can use a scissor,
okay.
or you can use the point which is less invasive and thinner one.
Okay. Okay. So in the operative hysteroscope, we can say like we can remove the fibroid or the
polyps, or you can open the tube with what we call a fallopian tube cannulation. You can do and open a closed tube. Or sometimes for women with infertility, sometimes they may have tuberculosis, to diagnose and take a biopsy from there. Or they have Asserman, so the lining is stuck, those adhesions, those also can be released.
Okay.
During operative procedure.
So does this hysteroscope like any kind of risk factor on
more or less a safe procedure?
Yeah.
But sometimes we have complications, like when the lady has 2 or 3 cesareans, it becomes very difficult to open the cavity, open the passage. The cervix may be stenosed. Then there may be chance of injury. Sometimes the chance of perforation. And sometimes there may be chance of infection which is not done well. But more or less these don't happen. But the patient has to be counseled that sometimes can happen. A difficulty, sometimes you may not be able to go in also. Sometimes you may abandon the procedure, very rare. And once you go in, you should see things properly. If you don't see them, then you call it a suboptimal thing what you have done.
Okay. Okay. So in those cases, like generally what we do when the visibility is not that clear?
Visibility is not clear, there are many things. The distension may not be good. Sometimes we may not be able to dilate well.
Okay.
But most of the time, 98% of the time we have a successful hysteroscopy. It's rarely that we have. And sometimes when it is stenosed, we can use something to open the cervix. Like we procedure we put mesoprost. If we think she had stenosis, we can't. Sometimes under the guidance of hysteroscope, we can open those passages also. We can
Okay.
use a scissor to cut and go. Sometimes we give other injections to the cervix to help us open the passage.
Okay. So should we call it as a major surgery or how
When
it
you do
is?
only a diagnostic, it's a minor procedure. But when you do operative, we use lot of fluids. Like when you may use a normal saline, or you may use glycine, which has other side effects also.
Okay.
So we have to be very careful when we do the fluid management for these patients. How much fluid is retained inside. If we find there's more fluid loss, retention, or deficit, we have to stop the procedure. So we have to be cautious when it is a operative hysteroscopy.
Okay. Okay.
So it is a major procedure when it is, though there is no cut, it is done through the natural passage, but it is a major procedure. Otherwise, diagnostic is a minor. It can
Okay.
even be done in office setting
Oh, okay. Okay.
sometimes.
So is it like painful, ma'am, or
If you do in office setting without any anesthesia, people fear, they're apprehensive, you have to counsel them before, or sometimes you can give some block there and then do, but most of the time we prefer giving a short GA, finish the procedure in 15-20 minutes, patient is out.
okay? And the operative hysteroscope, like what is the recovery time period after this?
Whichever way patient goes, is a daycare procedure.
Okay.
After 3-4 hours, once the anesthesia effect is gone, they can go. Only if they have complication with operative, they have to stay.
Okay.
Otherwise, most patients go home.
So they can like join office, start
Yeah.
regular care.
They can within 1 or 2 days they can resume. Next day, actually, in diagnostic you can. Operative, it may take 1 or 2 days for them to settle and then be okay.
Okay. What condition can be treated using the operative?
Mostly we do polyps, fibroids which are in the cavity. The FIGO, we have a grading for that. FIGO 0, 1, 2 can be done with the hysteroscope. And slowly when it goes into the myometrium, we need more expertise to remove those fibroids. When it's very big, occupying the cavity, sometimes we do in a one sitting, sometimes we may have to do in 2 sittings if there's a fluid deficit or it's too big.
Okay.
And Asherman syndrome, there is adhesions in the cavity, patient doesn't get periods. So infertility procedures also can be done. If the tube is closed, we can do FTC, fallopian tube cannulation, and open the tubes.
Okay. Okay. So generally, like how long does it take, ma'am, the surgery?
Surgery mostly depends on the size of the fibroid or polyp, or mostly within half an hour surgery is complete. But if you have a big fibroid, we have to resect for a longer period of time. But we see the time too long we cannot take when you're using that fluid to distend. So we have to see all that. We have to see the deficit. It should not exceed 1000 ml when we are using glycine, or 2000 or 1500 when you are using normal saline. All that has to be seen. The longer the procedure, we have to be more cautious and careful.
And the anesthesia time.
Anesthesia time, yeah.
Okay. Can this fibroid or polyps like be completely removed?
Yes. It's very actually. It's a very good thing. And one more thing I forgot is in postmenopausal lady, when they have postmenopausal bleeding, they usually come. The most important cause of doing a hysteroscopy is abnormal bleeding. Okay. That if they come even in postmenopausal women, most of them do have endometrial polyps. So we can do and same sitting remove. The women may not even need a big surgery like a hysterectomy. If we can remove the fibroid hysteroscopically, the uterus is spared. Okay, most of the time we do that. We can see if there's minor things we can do, and even she can get an intrauterine device. It's actually a good method when you know hysteroscopy, operative hysteroscopy, and you can do a uterus sparing surgery.
Okay. What is that? I mean,
that means without removing the uterus. You need not remove the uterus. Hysterectomy need not be done.
Okay. Does this operative hysteroscopy like affect fertility?
It doesn't affect fertility. Actually, it improves fertility. Many times it improves fertility. Because if you have a tumor inside, the woman may not conceive. If she has adhesions inside, she may not conceive. So it improves her fertility. The tube is closed, she may not conceive. So many a times we may do it to improve her fertility.
Okay. So what are the symptoms we can say, like how they can come to a doctor?
Most important is heavy menstrual bleeding.
Okay.
If somebody has a heavy menstrual bleeding, they may be having a polyp or fibroid. And polyp more often they have more of spotting and irregular spotting in between periods.
Okay.
Okay, and some people like older women after the period has stopped, they come with postmenopausal bleeding.
Okay.
And we can, one thing is for them, again we have to think, but rule out a cancer. Even that can be done when we do a hysteroscopy.
Okay, so there might be chances, like in the hysteroscopy also we can find out actually whether the
Yeah, we
cancer.
can see, there are many signs. I mean, when we see that growth, we can make out whether it's a polyp, whether it's a necrosed polyp, or it is cancer. We send for biopsy, but
Okay.
most of the time when we see that, we can have an idea what it is.
Okay, so the first we generally do the surgery, we remove the polyps or
Fibroids or whatever, and
then
send
we
it for
send
biopsy.
biopsy. Okay. Then after that we find out if there is any cancer or anything.
Yeah.
So based on that we can do the treatments. What kind of precaution they should take before the surgeries, or so that these things will not happen in the future to them?
The time of doing the surgery is important. When we
Okay.
post them for a routine hysteroscopy, usually we do it after the periods,
Okay.
when the lining is thin, so that you can detect a polyp. If you do it very late before her cycle, then you will find everything is looking very thick. You can't detect polyps and all that. You cannot know some changes in the uterus. The best time would be after periods to post them routinely. But it's not like if she's bleeding intermittently, you cannot do a hysteroscopy. You can always do. We have the distension medium which will wash out. With little bleeding and all, we can still get it done. But when we select a time, it is for routine case, it is like that.
Okay.
And any preparation, if they have previous 2 cesareans, we'll tell them what to do before, so that the cervix can be opened.
Okay.
And can the instrument can easily go, the scope can easily go in.
So then, like, how many cases it comes in a day? Like,
Yeah, many cases. Hysteroscopy is the most common performed surgery. I do a lot of hysteroscopy because now we don't do a blind DNC. Anybody who has abnormal bleeding or intermenstrual bleeding, or we do it. That's for bleeding. That is one. Postmenopausal bleeding is one. Infertility also, when we are doing for hysteroscopy, laparoscopy, we always combine with the hysteroscopy so that we see everything is okay in those people.
so there is no such link for the infertility. No, I mean it's improved the.
It improves fertility. It's not that that when you do a hysteroscopy, it makes her. I mean, reduces the chances of fertility. Only one thing we should keep in mind: when the big fibroids inside the cavity, and we do a resection. If we do that way, then we will, destroy most of the endometrium. So that has to be explained to the patient. It's too big. We maybe have to do a laparoscopy and remove rather than spoiling her endometrial lining. In some cases, it's by case to case basis. When we see things, we explain.
Okay. Before this laparoscopy, how they used to do? I mean, it's like open kind of surgery earlier.
Before laparoscopy, it was mainly open procedure. Then it came to be laparoscopy, which is more minimally invasive. But hysteroscopy has a different route of approach.
Okay.
For different things, and actually, a good one to complement a laparoscopy, I would say.
Okay.
Hysteroscopy will not replace that. It's different things for doing different method of surgery, but it is a complement in many cases.
Because in all earlier cases, if we'll see before the laparoscopy, I think it will.
It was
the
open
recovery-
surgery.
Open surgery. The recovery time must
Time
be
was
very.
it was long. Now with laparoscopy, the robotic, we have slowly made it more minimally invasive.
So robotic also can be done in the hysteroscopy.
No.
Not
Hysteroscope is a different day. Different is seeing the uterine cavity only. Laparoscope is different from above. We do a pneumoperitoneum, go from above and do the procedure.
Okay. Well, thank you so much, ma'am. So now I'll be asking a few rapid fire questions. Like you can answer in few words. It's not.
Not
limited,
yes
like,
or no.
Yeah.
Okay,
not
fine.
yes or no. Like in few words also you can explain.
Okay.
Yeah. So are you ready, ma'am?
Yes.
Okay. So operative hysteroscopy, like the minimal invasive, it's a like
A minimal invasive.
Earlier I have asked also these things. I mean, it comes under the major or the minor surgery.
It's a major
It's a
surgery.
major
If you do,
surgery. Okay. Can it be done without like anesthesia?
No. Operative cannot be done without anesthesia. Diagnostic can be done, but not operative. Very small things, maybe with a small scissor patients have to be mentally prepared for doing it, polypectomy or without. It would be safer for them to go under, because now anesthesia and everything has become much safer rather than give them pain doing operative procedure. Small polyps and small if it's just there, pull out, they can't make out, it's okay. But it's bigger ones, it needs anesthesia.
Just need
Yes.
And what is the biggest myth about the hysteroscopy?
Well, it can't be done when the patient is having irregular periods or when the patient is having little bleeding. And the more important is they think it is painful process with lot of anxiety.
That was my next question actually.
Yes.
Biggest fear.
Biggest fear is pain. They're very anxious how it will go, but they're all relaxed. I usually do it with short GA.
Okay. Okay. And does it help in treating like heavy periods?
Yes, yes. If you have, they have fibroids, polyps, we do that. And there's another method called TCRE. We can, what will you do? You can resect the endometrium.
Okay.
Or use a roller ball to cauterize it if they have bleeding. But nowadays we don't do it too much because we have IUDs, LNG IUDs, which can also reduce the bleeding.
Okay.
After doing that, we can always introduce
So it
LNG.
Bleeding, it's because of the internal, I mean the
If it is only if the endometrium is thickening.
Okay.
So nowadays we put a device like LNG IUD, hormone containing device to make the lining thinner. But previously roller ball and all was more common. But now we only remove the cause of the bleeding, and we send for biopsy, curate it out and
So
send.
the roller ball used to be for the coagulation.
Coagulation of the endometrium.
Okay.
Lining.
Okay. Okay. How soon can patient should return to the work? This also
Next day.
we have already discussed.
She's all good.
And pain level like mid or moderate or it's severe pain?
Mild. She may just experience cramps the same day or next day with little bit of spotting or bleeding. That's all that she has.
Can hysteroscopy prevent future surgeries?
Yes, obviously. That's what I discussed. You need not have to go for hysterectomy. Many of the cases you can prevent.
Okay. Like one thing women should not ignore about the reproductive health.
Well, they should go for routine screening. That's important.
Okay.
And if they have heavy menstrual bleeding also, they should return to the doctor, not get very weak, anemic and then come. That's what we find in women. Hemoglobin goes down to 6, 7 and then they come and see the doctor. So one thing is heavy menstrual bleeding should not be taken lightly.
Okay.
If they are passing clots, that's also heavy. If they're changing too many pads in 2 hours, then that's also heavy. If they have to change a pad in 2 to 3 hours, that's also heavy. That's what women should know.
Okay. So after the pregnancy, I mean the baby birth and everything, I think that is the common symptoms, the heavy bleeding, it happens, right? I mean, if I'm not wrong.
After birth, no, you can't say after birth it happens, but some people may have it.
Okay. Yeah. That's all, man. Thank you so much for your valuable experience, sharing all your knowledge with us. Thank you.
Thank you.